I have to declare some possible conflicts of interest. I'm a technical expert for accreditation bodies in Europe and in other countries. I got travel support and lecture fees by some companies. I'm a member and proficiency testing supervisor of Instant and proficiency test provider. What we are doing in our laboratory is cellular immune monitoring. We can do a lot to support our clinical partners and to help the patients. We detect immune cells. We look for the differentiation of the cells and for the maturation. We analyze immune function. We can detect the efficacy of therapies. Many of the therapies given today to patients are immunologically based. We detect or also exclude infections in patients, for instance, CMV, tuberculosis. And we can also analyze in the context of tumor therapies, double-strand breaks in cells. The main methods in our laboratory are flow cytometry, of course. This is also the topic of my today's speech, but also epigenetic methods, and of course, some microscopic techniques. Epigenetics is very interesting because this can also be used in immune monitoring in the neonatal screening and has a very close connection to what we are doing in flow cytometry. Primary immunodeficiencies are very relevant today. They are considered to be rare diseases, but I will show you that this is not true. The clinical representation of primary immunodeficiencies is dominated by infectious diseases, but also by autoimmune phenomena and by malignancies. That's why we moved in the wording from primary immunodeficiencies now to inborn errors of immunity. These diseases are genetically very heterogeneous. We know today more than 485 different syndromes with innate errors of immunity. They affect distinct components of the innate and adaptive immune system. And they must be distinguished from secondary immunodeficiencies, from infectious, disease-related, therapy-induced, and so on. So when we get a request for analyzing a primary immunodeficiency, we every time first ask for exclusion of an HIV/SIDA infection. I told you it's not really a rare disease. I show you the frequency of inborn errors of immunity. Rheumatoid arthritis is not an immunodeficiency. It's a very common disease. 1 in 100 to 200 people is suffering from rheumatoid arthritis. Gluten enteropathy, 1 in 200 to 800. Type 1 diabetes, a very important disease, 1 in 600 to 800 people. And multiple sclerosis in 1 in 800 to 1,000 people. So primary immunodeficiencies with 1 diseased person in 250 to 500 people is exactly in between, and you probably will agree with me that this is very important. Of course, there are many different primary immunodeficiencies, and so the single disease can be very rare, but in some, the primary immunodeficiencies or inborn errors of immunity are very common. Nevertheless, the awareness for inborn errors of immunity is still very, very poor. Because primary immunodeficiencies are very common, there is a need for newborn screening. The severe combined immunodeficiency is a pediatric emergency, and untransplanted patients die within the first year of life. When we early transplant a bone marrow to these diseased children within the first 100 days of life, this is really life-saving. Here you can see in an older publication from Buckley and co-authors that survival depends directly from the time of transplantation of bone marrow. So when we find out that there is a primary immunodeficiency within the first few days, the survival is more than 95% or around 95%. This means when we identify a severe primary immunodeficiency, it should be found out early. To screen newborns for this primary immunodeficiencies, we use a technology to analyze the rearrangement of gene segments for T and B cell receptors, TRACs and CRACs. As you probably know, the genes for immune receptors are not encoded in the genes as a whole sequence, but they are rearranged out of gene segments. And during this formation of the gene segments, excision circles are cut out of the genes, and these circles can be detected by a PCR. And in Germany, this newborn screening has been added to the general screening of newborns in 2019. And now we get sometimes a year, in Leipzig, for instance, up to 10 times a year, the warning site that there are around there are very few TRACs in the blood, and these children are suspicious on an immunodeficiency and then can verify it by flow cytometry. The screening is done by the TRACs, and we do the exploratory tests for patients suspicious on immunodeficiency, and can this way confirm that these children need a transplantation or not. Furthermore, we use the IEI screening also for the monitoring of patients treated with immunosuppressive drugs. We recover the following follow-up of cellular therapies, and we analyze the cellular immune response in children with immunosuppression. To do this, we use a flow cytometer. There are many flow cytometers available in the market today, but they all have similar principles. They use a single cell suspension, fluorescence dyes, and the analysis is done by multicolor analysis. The cells go through a laser stream, and dependent on the technology we use, 10, 12, 14 colors in parallel can be analyzed today to analyze exactly the cellular composition in the peripheral blood. We use very modern machines, but in many medical laboratories, this is not common today. Majority of laboratories in European countries today use flow cytometers with 8 to 10 colors. Some have only 4 to 5 colors. And otherwise, some of these laboratories are equipped with research machines, and some of them can analyze 30 different colors. But in general, the most common finding is 8 to 10 color machine in medical routine laboratories. The reagents in majority of laboratories is IVD, but not in flow cytometry. In flow cytometry, IVD test kits are very rare, and most laboratories use lab-developed tests, often in-house validated. And this way they use also research use only test kits, and this brings a lot of regulatory problems with the IVD regulation in these countries. A very common approach is to use a screening tube, so-called immune status. Most of you will be familiar with this tube. Depending on the scatter and the CD45 staining, lymphocytes can be identified. These lymphocytes can be divided into CD3 cells and NK cells. NK cells CD1656 positive, NK T cells positive for CD3. There are some NK T cells and some cells that are non-NK or T cells. Majority of these cells are B cells. B cells positive for CD19, T cells positive for CD3. A lot of cells non-B, non-T, this means NK cells. And the T cells can be subdivided into T helper cells. These helper cells are CD4 positive and cytotoxic T cells CD8 positive. Some are double negative or double positive. These are early forms traveling through the thymus. What we cannot find here is a more detailed information about T cell maturation. We get no information about RTEs. RTEs are the mesenchymic emigrants, cells leaving the thymus as new formed T cells. We have no information about gamma delta T cells. We cannot detect HLA-DR, but absence of HLA-DR is a very common finding. We have no information about B cell maturation, no information about plasma cells. And this means in detail that we can miss immune dysfunction in these patients because the pure immune status gives us only a very crude general overview. How could we find out more? And the most common approach is to use many tubes. With many tubes, we can add to the screening tube a B cell differentiation tube, T cell differentiation tube, maturation tube, activation tubes, and so on. But with these many tubes, we have a problem. It will become very expensive. We have a high workload in the laboratory. We need a lot of blood, a problem in children. We have a poor comparability between the laboratories. In Germany, I'm responsible for proficiency test in flow cytometry, and we have high discrepancies between laboratories using different platforms and gating strategies. And we have the risk of missing relevant information. What to do now is that we in the moment still use additional tubes in cases that are highly suspicious on immunodeficiencies. We have a B cell tube. We can differentiate between naive, immature, CD21 low and memory cells. We have non-switched and switched B cells, transitional ones, plasmablasts, activated and immature transitional, and plasma cells. A lot of cells out of this one tube. For the T cells, we differentiate the T cells into naive, central memory, effector cells. Here to see again, and we also analyze CCR5 as a parameter of this function. The Treg cells, regulatory T cells, are very common detected in laboratories. We get to the CD25 positive, CD127 weak positive ones. We can differentiate activated Tregs and memory Tregs. The main problem in this approach is with the surrogate markers CD25 and CD127, we can miss Tregs in Treg deficient children with the IPEX syndrome. So for these children, we have to apply intracellular staining. RTEs are a good tool to find out how the thymus populates the T cell population in the body. In the naive T cell population, by getting to CD31 and so 45, RTE can be detected. And what is also important in this tube, we differentiate between alpha beta and gamma delta T cells, because gamma delta T cells are very important in some infections and also in graft failure following a bone marrow transplantation. The NK cells can be differentiated into CD56 bright cells and low cells. We have some functional markers, for instance, CD57 as a maturation and exhaustion marker. Majority of these markers has not yet an important function in diagnosing immunodeficiencies. As you have seen, all of these tubes require a lot of additional work, and what we thought about was how can we improve it? And together with Beckman Coulter, we developed some years ago an improved PID panel, one tube only, that can be colored, that can be used in any flow cytometer with 8 colors. This means this tube is really platform independent. It's very important. Such a tube can be applied to many flow cytometers in routine laboratories and helps to detect many immunodeficiencies. You see that besides the classical markers, there's also CD27, CD38. There is in some channels a double application of antibodies. So this has to be separated later, for instance, CD19 and CD8 in one channel. And when we use this tube, we start here with a scatter. Then we find out that there are a lot of cells that are CD45 positive. We can differentiate the T cells, the monocytes, eosinophils, neutrophils, and K cells, the B cell population, and the basophils. So we start with the principal populations. Everything out of one tube, platform independent. From this tube, we continue to within this tube, we continue to fossil populations. We can discriminate between CD8 positive T cells, CD4 positive T cells, helper and cytotoxic T cells. We can follow the maturation of the CD4 cells, naive cells, central memory, effector memory, TEMRA, and the same for the CD8 positive cells. You see the EMRA population is higher in comparison to CD4, and also the B cell population from naive cells via marginal zone to switched memory cells can be differentiated inside this one tube. And the NK cell populations, primed NK cells and low cytotoxic cells, and the monocytes, classical and non-classical monocytes, can be discriminated. The advantage of this PID screening tube is that the detection in children found by track screening can be done with one tube and flow cytometers. This is also suitable for a weekend when there's only one technician on duty. So primary immunodeficiencies and secondary immunodeficiency screening can be done in children and adults. We have easy implementation due to a pipetting-free dry panel format, no wash protocol. Honestly, in my laboratory, we wash it because we find the quality of gating is better, but you could do it without washing. We cover also the important late cellular differentiation states, and the compatibility with common instrumentation is very good. But there are also two disadvantages. We have a missing HLA-DR detection, so the bare lymphocyte syndrome cannot be detected when we have a limited number of available colors, because we are limited to these 8 colors available in machines of the main manufacturers. Another group here in Colombia or in Latin America developed an alternative PID panel, also one tube only, but with 10 colors. This is also research use only tube. It has been developed by colleagues from Beckman Coulter, includes also HLA-DR, and is designed with 10 colors. This means for the application of this tube, for instance, a machine like the DXFlex is superior and can be used for analysis of cells. Okay, it's not platform independent, but the information you get out of this tube is very, very good and is also very detailed. And the bare lymphocyte syndrome is really an important diagnosis. So this can be covered by this tube. It's better in the information because one very common immunodeficiency is covered, but the problem is you are now bound to flow cytometry from Beckman Coulter. Besides these populations, the investigation of immune function is very important because only the existence of the cells is not enough, and the cells have also to be functioning. So there is a differentiation between Th1, 2, and 17 cells. This can be analyzed in flow cytometry. We can analyze antigen-specific proliferation, for instance, to detect cells reactive to viral infections. The lymphocyte proliferation test is done in majority of laboratories, not longer by adding radioactively labeled nucleotides, but by proliferation tests in flow cytometry. Phagocytosis, oxidative burst, and migration of the cells can be investigated by flow cytometry. For instance, we recently got blood of a child suffering from fungal infections, and this was very interesting because these were twins. One was completely healthy, one was sick, and in this case we investigated Th17 because defects in the Th17 signaling very often are combined with fungal infections. So we stimulate T cells. It's an intracellular staining in T cells, and we activated the cells by PMA and ionomycin. And as you can see here, the healthy sibling expresses IL-4, IL-17, and also interferon gamma in his T cells. So Th1, Th2, and Th17 cells can be detected. In the patient, we find IL-4, we find interferon gamma, but there are nearly no Th17 cells, so interleukin 17 cannot be detected in this child. This is, of course, a challenge, and challenge because the only consequence out of this situation is a transplantation of a healthy bone marrow to this child, or otherwise we have simply to manage this situation and to handle it during the life, and we know that this child will be very sensitive to fungal infections. The detection of infection in immunocompromised patients is another challenge for our laboratory. Here I show you the detection of CMV in cells of patients by help of a tetramer staining. Here's a negative control. This patient didn't have a positivity for CMV. This is a CMV negative cell patient without detection of CD3 positive tetramers. This is only background, but here there are lots of CMV positive T cells in this patient, can be detected by a tetramer with CMV peptides. This is a good technology, but has also some limitations. The reagents have to be in MHC matched. The majority of this MHCs is only available for MHC1. And so the main application today is the detection of viral infections. For other applications like autoantigens or for very rare infections, these tetramers are not available, and so most laboratories work with cell culture experiments and batch stimulation assays. The challenge for all these tests in flow cytometry today are as required blood volume. Many primary immunodeficiencies are found in small children, in newborns, and the required blood volume is limited, and we cannot analyze many tubes in parallel. So a good clinical diagnosis and a good investigation of these children is very important, and also the family history is very important to identify early the children on risk. This is also a challenge that is closely connected to the search for new methods. For instance, with a mentioned epigenetic methods, we can do an immunophenotyping of the T cell populations with a very small amount of blood, and this is very superior for this application because we can use dry blood cells. The pre-analytical information is very important. Without a correct information from the clinician, we cannot decide what to analyze. When I get blood from a child and the question is only immunodeficiency, I can do exactly the wrong investigation, for instance, when this immunodeficiency has to be seen in the context of a bone marrow transplantation. So I have to combine the correct tubes for the investigation dependent on the clinical information from this child. The awareness is very poor in our population. So some people are suffering from immunodeficiencies. I recently have seen an investigation of older people, 65 years plus, and even in this population, a lot of primary immunodeficiencies could be identified. The training and counseling of medical doctors has to be improved. That's why you also are now performing this symposium, and I congratulate you that you are offering such an event. We have missing consensus protocols. This is a really challenge because without consensus protocols, the results between different laboratories cannot be compared easily, and missing standardization is really a problem. Most companies don't provide IVD test kits that can be used easily from the shelf, so we have to develop our own tests and have to set up our own reference ranges and have to do validation in the laboratory. And these missing reference ranges are very important because in early childhood, the subpopulations are completely different to the situation in adults. And this cannot be interpreted in a correct way without knowledge of these reference ranges in detail, and this is still in progress because this collection of blood values from healthy children is very challenging. I would like to thank you for your interest in my work. I would like to thank my colleagues, Katrin Bauer, Stefan Borde, Jesus Alvarez from Beckman-Coulter, Michael Kapinski from Beckman-Coulter, Oliver Pelz-Ackermann from Becton Dickinson, Michael Bitar, Bettine Glatte, Sabine Seifert, and Andreas Bolt. And I thank you for your attention.